Steroids are a class of medications that have anti-inflammatory properties and also properties in regulating cell metabolism for all sorts of cells in the body. In the case of muscle disease, we know that use of steroids can slow progression of Duchenne muscular dystrophy. We know this because of some very good clinical trials that have been performed over the last 25 years. Two steroids are predominantly used in Duchenne and Becker muscular dystrophy. The first of these is prednisone or prednisolone, and the second is deflazacort. Both drugs have been shown to have rather equal efficiency or efficacy in slowing progression of disease in the best trials. The major question for use of both drugs has to do with their side effects. The absence of dystrophin makes muscle membrane more susceptible to injury under contraction. As the membrane is damaged, there's an influx of calcium, which sets up cycles of degeneration within the muscle. Secondary cascades of degeneration, all sorts of intracellular processes that cause degeneration of muscle. In addition, there's inflammatory cells that come in that clear away the necrotic debris after muscle cells degenerate. After this process, muscle regenerates, muscle fibers regenerate. And it's thought that progression of Duchenne muscular dystrophy really becomes obvious as the muscle loses its regenerative capacity. Steroids probably interrupt these cycles of degeneration by interrupting them at several spots in this cascade. They decrease the amount of calcium influx in damaged muscle. They interrupt secondary cascades of degenerative processes. In addition, we know from experiments in animals and in cell culture that steroids seem to decrease the amount of muscle protein breakdown and increase muscle mass in both animal models and human trials. So there's very good reasons to suspect that they might delay the cycles of degeneration, or diminish the amount of degeneration that occurs in Duchenne muscle. About 25 years ago, early papers suggested that there might be a benefit from treating boys with daily steroids. And after the initial reports in small groups of patients, larger trials were organized. Through these trials, they demonstrated that a dose of about 0.75 milligrams per kilogram per day of prednisone showed efficacy in slowing progression of Duchenne dystrophy when measured by the time to loss of ambulation. And they generally showed that you could delay loss of ambulation from about 18 months to 2 years, depending on exactly which trial you look at. But within that range, you could gain that much ambulation time. Now, at the same time, these trials demonstrated that the side effects of daily prednisone were present. Prednisone has several side effects that all steroids are apt to have. These include primarily weight gain, hypertension, cataracts, problems with handling blood glucose, changes in the fat distribution in the body, so particular moon facies, we call it. All of these are side effects that do and did occur in these trials with prednisone. It's I think the common clinical consensus that many of these, particularly the weight gain, can be diminished by a fairly aggressive monitoring of nutritional status and caloric intake. Two other complications of steroid use are behavioral changes and osteoporosis, or thinning of the bones. In a search for ways to diminish the side effects, people tried other regimens of prednisone, including every other day dosing. It was shown that every other day dosing of prednisone with roughly an equivalent dose didn't have the same sustained benefit that daily dosing had. Other regimens have been tried, including 10 days on prednisone and 10 days off prednisone, cycling in that fashion. More recently, one group from St. Louis, Dr. Connolly's group, published a paper suggesting the use of weekend steroids at very high dosage may be of benefit, with relatively few side effects. An alternate way of trying to avoid side effects besides these dosing regimens was to use an alternate compound Deflazacort being the most popular. Deflazacort's a derivative of steroids, but seems to have less side effects in its use. However, Deflazacort is still not available in the U.S. and not available in many countries, so prednisone is still an option in many settings. And in fact, head-to-head trials of prednisone versus Deflazacort have not been adequately carried out or published. So what our community, the Duchenne community, needs now is controlled clinical trials comparing various regimens of prednisone to Deflazacort. One question parents often ask is, when should steroids be started? We don't exactly know the answer to that, but there's reason to think that starting earlier rather than later might be of benefit. It's my experience that starting boys who are about to lose ambulation in the hope of somehow staving off loss of ambulation doesn't really work. In our clinic, we discuss with the parents the various treatment options and the risk of side effects, and hopefully come together to an informed choice about when a boy might begin steroids. The question of when to stop is also often raised. The clear endpoint in many studies was loss of ambulation, and in many clinics steroids are stopped after that point. There's a growing body of evidence that suggests that continuing steroids after a boy is in a wheelchair improves his pulmonary outcome and improves perhaps the cardiac outcome as well. So I think that the consensus is moving toward treatment after loss of ambulation in the long term. Parents sometimes also ask about changing drug regimens. If a boy is on daily dosages and his hyperactivity or irritability is interfering with schoolwork, it seems a reasonable choice to offer or consider weekend dosing regimens in those boys. Again, the understanding has to be that at the present time, we don't have good clinical evidence that the weekend regimens are as good as daily dosing, but I'm hoping that clinical trials in the near future will help to clarify that. In spite of the possibility of side effects, I feel and I think there's a growing consensus that the side effects can be managed and that we can provide a clear benefit to boys to keep them out of a wheelchair for an extended period by the use of these drugs.
Of all the therapeutic drugs that have been studied in Duchenne's muscular dystrophy, only corticosteroids, i.e. prednisone and Deflazacort, have the potential for providing interim functional improvement while we await a curative therapy. They belong to a class of drugs that have been used for its anti-inflammatory action in various medical conditions like severe asthma, inflammatory arthritis like rheumatoid arthritis, and steroids itself has been shown in studies since 1974 to have a benefit for boys with Duchenne's muscular dystrophy. The definite benefits of having steroids for treatment of Duchenne would be definitely one, muscle strength will be improved to the point where the boy will be stronger and be able to walk much longer. If it's untreated, most of the boys will lose the ability to walk between 8 to 10 years of age. But with the treatment of steroids, we would be able to prolong that period of walking by another 4 to 6 years. For some, it may be 2 to 3 years, but definitely that's much longer than if the boy is untreated. And with the ability to walk longer, we would be able to avoid the development of scoliosis, which is where the spine gets into an S-shaped curve as a result of muscle imbalance, and that may require surgery. So the other additional benefit may be avoiding the need for major surgery like scoliosis spine surgery. 2, these boys would have stronger breathing muscles, and with steroids, the lung function will be much improved. So much so that in the teen years, they have fewer respiratory complications or pneumonias and hospital admissions. Ideally, one would like to start steroids while the muscles are still in good shape, i.e., between the ages of 4 to 7, when the boy has the strength to run, to get up from the floor without too much difficulty, as opposed to when the boys have lost the ability to walk. So we would get comparatively greater benefit if we are able to start early, between 4 and 7 years of age.
In Toronto, Canada, where we are, we've had over 10 years of experience with steroids. The steroid we use in Toronto is a steroid called deflazacort. And deflazacort is very similar to prednisone, except it's been developed because it has fewer side effects than prednisone has. And the side effects that we worry most about for boys with Duchenne muscular dystrophy is the side effect of weight gain and changes in their behavior. This drug, in our experience in Toronto, is that it has not nearly the side effect of the excessive weight gain and the negative effect on their behavior that commonly is seen in boys who take prednisone. Families and boys with Duchenne muscular dystrophy should consider using steroids, and in our experience, deflazacort here, because steroids have been shown to affect, in a very positive way, the natural history of boys with muscle weakness getting worse who have Duchenne muscular dystrophy. So the time of starting would be when they're young, when their muscles are still working, and steroids really offer the only hope today, the only hope for giving these boys better function for longer. And what you're really doing is adding to their quality of life while they have hope for something more curative, more long-lasting than steroids will be. A very important question for the boys and their parents is to when to start to use the drug, deflazacort. We've had a lot of experience with this drug now, over a decade of experience. 10 years ago, we were a little nervous with this drug. It was new. It had a reputation, like prednisone, of possibly having some bad and serious side effects. So we were quite conservative. When we would start the boys 10 years ago, we would start them when they were 7 and 8 years of age. At that time, the parents would say to us that their son was struggling more, having difficulty getting up from the floor, climbing stairs, and more tired at the end of the day. It's very important in this disease, if we're going to treat it effectively, is we treat it early, because once the muscles become weak, we can't get that back again. So now that we're more comfortable with the drug, now we know that the drug doesn't have a lot of side effects that are difficult for the boys, we start the boys when they're younger. Typically, we start them when they're about 5 to 6 years of age. A second important question is how to administer the drug, what regime to use. In Toronto, we use deflazacort on a daily basis. Every day the boys get the medicine first thing in the morning as a single dose. In other parts of the world where they're having difficulty with prednisone and the side effects, they're trying many different regimes. Every other day, a few days on, a week off. We're not doing that because the side effects that we've seen here are so limited and so tolerable that we find that the daily deflazacort is tried, is trued, and we'll stay with that until something comes along to tell us that it could be done differently and better. If we look at our experience over the last 10 years, we've seen areas of change in 4 important ways. One is the boys walking, the boys breathing, their spine, and their heart function. First, the boys' muscle function and walking. We have seen that on deflazacort, the boys will walk 3, 4, maybe 5 years longer than boys who are not treated with deflazacort. And this walking is real walking. They're not using braces. They're not using walkers. They're walking unassisted. They're walking in their classroom at school and at home. So this is truly quality walking, and they're not afraid of falling. The second area is their breathing. And as you've heard, breathing typically starts to decline after the boys turn 10 years of age. On deflazacort, their breathing remains perfectly normal for 15 years, so there's no change between 10 and 15 years. And now as the boys are getting older, it looks like there might be an early change around 18 to 19 years of age. So there's a very, very significant improvement and preservation of their breathing function. The spine, again, as you've heard, the spine typically requires surgery in most of the boys in their mid-teens. The boys on the Flazicort, very few have required any spine surgery at all. They're now into their early 20s, and we're not sure if they'll ever need spine surgery or whether they've escaped that period when they're vulnerable and susceptible to developing the scoliosis or the curve of the spine. So certainly the spine surgery has been delayed, if not perhaps prevented. Only time will tell. And the fourth area is in the heart muscle. The heart muscle is involved, as is the walking muscle and the breathing muscles. And so we have just finished a study to show that the heart in most boys is protected as well as the other muscles that we've talked about earlier. So those four areas, the heart, the spine, the breathing, the walking and the climbing stairs, all seem to be significantly preserved for a number of years in these boys. Now, it's very important now to look at the side effects. All steroids have side effects, as you've heard, and it certainly is a thing that we're concerned of. We have learned with our experience over a decade that the side effects are limited, as I mentioned, and they're certainly tolerable. It's important, as you've heard, that we watch the boys and their weight very carefully. So we're great on vegetables and we're not so lenient with candies and hamburgers. So we watch the weight very, very closely. The behavior sometimes is affected, particularly in the boys in the 7, 8, 9 years of age, when they're struggling already. Sometimes the Flazicort, for a short period of time, can make that struggle worse. But the boys usually outgrow it. Another area that's commonly involved, but not a problem, is the boys develop tiny little cataracts in their eyes. It's not cataracts where the eyes get cloudy and they need operations. The eyes have a tiny little speck in them. The boys can't see that they have any problem with their eyes. Their eye function is perfectly normal, and we have their eyes checked by an eye specialist as a routine every year. So it's not something we worry about. Another important aspect that some parents worry about, but the boys don't seem to worry about as much, is that their height is affected. And in fact, we don't consider that as a side effect, we consider it a benefit, because we've learned that the boys who do the best on the Flazicort are those boys who are thin and short. So being short is good. You might get teased a little bit at school, but certainly being short means your muscles don't have to work as hard, and means you're going to walk longer and do much better. Now, another area that's involved with Duchenne muscular dystrophy that may be affected also with the steroids is called osteoporosis. We know that boys with Duchenne muscular dystrophy do have some degree of osteoporosis. That's because they're not running and jumping and playing and working their bones to make strong bones. When we put the boys on the Flazicort, we make the osteoporosis worse. Having said that, though, we put the boys on large doses of vitamin D and calcium, and we don't see a